Before viewing this month's online CPD, please make sure you answer the pre-test. This is to assess if there is enhancement of your individual continuing professional development. Hi, I'm Dr. Marlon Moralion, a member of the Philippine Pediatric Society, Southern Tagalog Chapter, and a newborn medicine specialist. Welcome to Hindi Lang Simple Ang Lungs, an online CPD on respiratory distress syndrome. The objectives of this lecture is to define respiratory distress syndrome, explain pathophysiology of hyaline membrane disease, explain clinical manifestations in radiograph findings of hyaline membrane disease, explain treatment and prevention of neonates with this disease, and discuss prognosis of hyaline membrane disease. Respiratory distress syndrome is formerly known as hyaline membrane disease. It is the primary respiratory disorder among preterm babies secondary to surfactant deficiency, and still remains to be one of the most common causes of morbidity in preterm infants. RDS is common in 60 to 80% of infants less than 28 weeks, 15 to 30% in infants between 32 to 36 weeks, and about 5% beyond 37 weeks, and rarely at term. In the Philippines, it has a mortality rate of 11.2%. The main pathology of this disease is a decreased production and secretion of surfactant. There is a complex process of surfactant synthesis. Precursors are needed and is also regulated by various hormones that include corticosteroids. Let us review the synthesis and production of surfactant. The responsible cells for gas exchange in the distal respiratory epithelium are type 1 pneumocytes and type 2 pneumocytes. Type 1 pneumocytes covers the alveolus, whereas the type 2 pneumocytes contains the lamellar bodies and are the source of surfactant. The pathway of surfactant synthesis starts with pneumocytes type 2 cells containing the lamellar bodies, which is the source of the surfactant, are present in high concentration in fetal lung homogenates by 20 to 24 weeks of gestation, but it does not reach the surface of the lungs yet. The lung secretes fetal lung fluid, and the flow of fluid out of the lungs to amniotic fluid. Flow is episodic and results from fetal breathing. It is then present in the amniotic fluid between 28 and 32 weeks with the development of amniotic fluid phospholipid. However, mature levels of pulmonary surfactant are usually present after the 35th week of gestation. The components of a mature surfactants are lecithin, which is about 65% and is dominant in mature lungs, phosphatidylglycerol, which is present in mature lungs about 35 weeks and may be present in infants with early lung maturation as early as 30 weeks. Surfactant from mature lungs containing other lipids and surfactant proteins and cholesterol. For the pathophysiology, deficiency of surfactant into the alveoli increases surface tension and causes the collapse of small air spaces. This results to decreased lung compliance with inadequate lung ventilation and small tide volume, eventually resulting to increased work of breathing with insufficient alveolar ventilation and reduced lung volume. This will cause hypoxemia and eventually hypercapnia. deficient synthesis or release of surfactant, and structural lung immaturity, together with small respiratory units and compliant chest wall, produces atelectasis and results in perfused but not ventilated alveoli, causing hypoxia. Decreased lung compliance, small tidal volumes, increased physiologic dead space, increased work breathing, and insufficient alveolar ventilation eventually result in hypercarbia. The combination of hypercapnia, hypoxia, result to mixed acidosis, producing pulmonary arterial vasoconstriction with increased right-to-left shunting, with impaired endothelial and epithelial integrity within the lung itself. Pulmonary blood flow is reduced, and ischemic injury to the cells producing surfactant and to the vascular bed results in an effusion or proteinaceous material into the alveolar spaces, and this is why it is called hyaline membrane disease or respiratory distress syndrome. RDS in term neonates can also be seen because synthesis of surfactant also depends on normal pH, temperature, and perfusion. Meconium aspiration syndrome, asphyxia, hypoxia, and pulmonary ischemia, particularly those in association with hypovolemia, hypotension, and cold stress, may suppress surfactant synthesis. In infant of diabetic mother, hyperinsulinemia may cause displacement of choline in the formation of phosphatidylcholine, which is the mature component of the surfactant. Clinical features of RDS include tachypnea, prominent grunting, intercostal and subcostal retractions, nasal flaring, duskiness and/or cyanosis, increase and are often relatively unresponsive to oxygen administration. Breath sounds may be normal or diminished with a harsh tubular quality, and on deep inspiration, fine rales may be heard, especially over the lung bases posteriorly. Signs of HMD usually appear within minutes of birth. A late onset of tachypnea should suggest other conditions. If the condition is inadequately treated, blood pressure may fall, fatigue, cyanosis, and pallor increase, and grunting decreases or disappears as the condition worsens. Respiratory failure may occur in infants with rapid progression of the disease. In most cases, the symptoms and signs reach a peak within 3 days, after which improvement is gradual. Improvement is often heralded by spontaneous diuresis and the ability to oxygenate the infant at lowered inspired oxygen levels. Death is rare on the first day of illness, usually occurs between days 2 and 7, and is associated with alveolar air leaks and pulmonary hemorrhage or intraventricular hemorrhage. Diagnosis is made by combining the age of gestation and clinical course and a chest radiograph. Blood gas and acid-base values may also help. It may show hypoxemia and later by progressive hypoxemia, hypercapnia due to atelectasis and variable metabolic acidosis. Radiographically, the lungs may have a characteristic but not pathognomonic appearance that includes a fine reticular granularity of the parenchyma and air bronchograms, which are often more prominent early in the left lower lobe because of the superimposition of the cardiac shadow. This is the picture of a mild RDS on chest X-ray. You will see the reticulogranular pattern and air bronchogram with prominent cardiac borders. A moderate RDS on chest X-ray still has the reticulogranular pattern as shown in the left radiograph. An air bronchogram as pointed. But note that cardiac borders are not prominent. This is the chest X-ray of a severe RDS. Whiteout lungs and air bronchogram may still be seen. However, early onset neonatal pneumonia with GBS may also look like this. In terms of prevention, the most important prevention is prevention of prematurity, including avoidance of unnecessary or poorly timed cesarean section, appropriate management of high-risk pregnancy and labor, and prediction and possible in utero acceleration of pulmonary immaturity. Intrauterine antenatal and intrapartum monitoring may similarly decrease the risk of fetal asphyxia. Pharmacologic acceleration of pulmonary maturation via antenatal corticosteroid. Antenatal corticosteroid is widely used to enhance lung maturation. A Cochrane review of 21 studies, including 3,885 women and 4,269 infants, showed reduced risk of neonatal death by 31%, reduced incidence of RDS by 44%, and reduced intraventricular hemorrhage by 46%. Antenatal corticosteroid use is also associated with a reduction in necrotizing enterocolitis, respiratory support, intensive care admissions, and systemic infections in the first 48 hours of life. Two antenatal steroids are being used, dexamethasone or betamethasone, to women 24 to 48 hours prior to the delivery of fetuses between 24 and 34 weeks of gestation. Betamethasone is a better option because studies showed that it has a better neurodevelopmental outcome. Treatment. Since the primary problem is the deficiency of surfactant, we give exogenous surfactant at 4 cc per kilogram per dose. Administration of surfactant will result to improved mortality from RDS, improved oxygenation, FRC, and lung compliance, decreased incidence of air leaks, and exogenous surfactant doesn't inhibit endogenous surfactant synthesis. It is not simple to give surfactant because of its complications. Pulmonary hemorrhage typically occurs in the first 72 hours of life. Generally, deterioration in oxygenation and ventilation with cardiovascular compromise are typical findings of pulmonary hemorrhage. The increase in pulmonary blood flow results in pulmonary congestion and elevated capillary pressure that may result into intra-alveolar hemorrhage. PDA or patent ductus arteriosus results due to improvement of lung compliance causing an increase in left to right shunting. Bronchopulmonary dysplasia or BPD is now known as chronic lung disease. In a meta-analysis, this disease increased with the use of surfactant who are very preterm but is reduced among neonates at least 1,250 grams. This might be also a direct consequence of barotrauma or volutrauma among preterm survivors. Mainstay of treatment also includes assisted ventilation, fluid, electrolytes, and nutrition, thermoregulation, acid-base therapy, and antibiotics. For the prognosis, early provision of intensive observation and care of high-risk newborn infants can significantly reduce the morbidity and mortality associated with hyaline membrane disease and other acute neonatal illnesses. Antenatal steroids, postnatal surfactant use, improved modes of ventilation, and supportive ICUs have resulted in low mortality from hyaline membrane disease, approximately 10%. Mortality increases with decreasing gestational age. Good results depend on availability of experienced and skilled personnel, specially designed and organized regional hospital units, proper equipment, lack of complications such as severe asphyxia, intracranial hemorrhage, or irremediable congenital malformation. Surfactant therapy has reduced mortality from hyaline membrane disease approximately 40%. The incidence of BPD has not been measurably affected. The overall mortality in low birth weight infants referred to intensive care centers is steadily declining. 85 to 90% of all infants surviving from HMD after requiring ventilatory support with respirators are normal. Prognosis is better among newborns weighing above 1,500 grams. The long-term prognosis for normal pulmonary function is excellent. Some may have significant pulmonary and neurodevelopmental impairment. In summary, primary respiratory disorders among preterm babies is secondary to surfactant deficiency. RDS is a combination of surfactant deficiency associated with some structural lung immaturity. Tachypnea, grunting, flaring, retractions, and cyanosis are some of the features of RDS. Surfactant therapy and proper ventilation is needed for survival. Prognosis is good with surfactant therapy and proper ventilatory support. Please answer the post-test. You need to answer the pre and the post-test to earn CPD points for this online CPD, all for the Filipino child. Thank you.